Hello. All right, guys. Cheers. My sweet daughter made me fresh pot of decaf for the show for tonight. So I am enjoying one of my favorite decaf from the local fresh market around here. Yeah, that's good stuff. That's good stuff. All right, guys. I've got a really fun show for tonight. A lot of really great information that I came across this week, and I'm really excited to share it with you guys. It was kind of one of those like really wonderful light bulb moments with the show. So I'm going to give you guys a couple minutes to jump on board. And I see the numbers ticking up. So guys, if you're watching the replay, please comment replay for me so I can keep track of who's watching the replay, who's watching live. And also if you're watching the replay and you have any questions, go ahead and put it into the comment sections. I do try to trace it back and get any questions that were done with the replay. What are you holding, Brian? What are you holding? Are you holding your Bustelo, Brian? Hey there, Susan. Brett, iced tea. Wonderful. All right, guys. Those of you who are new to the show, that's kind of your hazing ritual. You got to let me know who you are, where you're from, and what's in your coffee mug. Everybody out there with the cool kids, Cosi Talks mug or glass, cheers to you. Hey, Bonnie, working in rehab. Oh, Bonnie, I'm so happy for you. I'm so glad that you had that procedure done. Everything's going well with you. Marianne, I've got your question here, darling, and we're gonna talk about this tonight. Kenny, good evening, guys. How are you? All right, Susan says she's got a Coke on the go, nothing in it, straight up Coke. Good for you, Susan. Good for you. All right, guys, we're going to give you guys a couple minutes to jump on board this evening where I think we're going to have a couple new viewers on, so I'm excited about that as well. All right, Kenny from Virginia Beach, Virginia. Brett, thank you for the emoji, Brett. We got Debbie. Hey, having my sparkling water in her Cool Kids Club mug. Oh, yeah. We've got Sandra from Gainesville, protein shake. All right, awesome. I love this. I love this part. This helps me get to know you guys a little bit better. Hey, Van Gregory, what's going on? Today is the 15th of September. Yes, you are, in fact, watching this live, Van Gregory. You're good to go, man. You're good to go. Oh, all right, guys. We're going to give you another few seconds left to go. All right, so here we go. Funniest thing happened today. I was in the car with my kids, and a lot of my kids did really well in their tests. Like, they all got, like, high A's. They did amazing work. So I was like, all right, let me treat you guys to, a bag of Skittles or something like that from the gas station. And I never do that. That's something I just don't ever do, right? So I go in the gas station, instead of just a bag of Skittles, I end up getting, I'm a sucker for those chewing gum, like the juicy fruit and the big red and the double mint. And I got 3 packs of gum. I ended up walking out of there. I looked like a kid in a candy store. Don't know why I just thought of that. Just something random that happened today. Hey, we've got Lynette. What's going on, comadre? Yes, I know. Finally got back in the pool this week. It's been a while since I've had a good swim, so I'm taking a little break from running. So guys, those of you who saw my video this week, I posted a video on how to handle muscle soreness, right? Anybody see that video? Do you guys mind give me a show of hands who saw that video that I posted this week at the pool talking about muscle soreness? Hey, Susan, have seen my son in 5 years and he's coming home. Oh, that's wonderful, Susan. Hey, Denise from North Carolina. There's my Tar Heel right there. So anybody see that video? Yes, show of hands. Maybe? No? There's always a little time delay here whenever I ask a question, and then I'm just staring at the screen. Hey, William, what's going on, man? Welcome. Let's see, Rick. Hey, Rick, Bonnie saw it. All right, thumbs up to the children. Oh, thank you, Van Gregory. You saw the video. Awesome. Kenny saw the video. Debbie, you haven't seen it yet. Guys, oh, thank you, Dick Devers. So, guys, this video is posted on my Instagram and my Facebook accounts. So it's just a little tip of the week that I'm going to try to do for you guys, just something a little shorter video. So on this one, it was muscle soreness, right? And a lot of times people think that muscle soreness comes from lactic acid buildup in our muscles. Lactic acid gets a really bad rep, but actually the lactic acid clears out a lot faster than you think, okay? What's causing the soreness is actually inflammation, right? So any of you who have seen my YouTube video on muscle strengthening physiology, I did a whole nice long video on how it really works. When you're strengthening a muscle, right, you actually create little tears, little micro tears in the muscle fibers, right? And as those tears heal, right, it gets your muscle nice and strong, right? So when the muscle is healing, your body's response is to produce a little bit of inflammation. And that's honestly what causes all that soreness and stiffness after you've had a nice long workout. So for me, the best way I found to combat that is actually with movement, right? So we want to rest the muscle in the sense that we don't want to keep strength training and overloading it because we're just going to keep breaking those muscle fibers and cause an injury over time. But we do want to create a little bit of movement. And the reason is with the movement, you can start pushing that inflammation out of that area. And the reason why I shot it at the pool is because on Sunday, I'd given myself a really good beat down with my own workout and I was really sore. My favorite way is going in the pool and just doing some really gentle laps in the pool, right? Helps keep my joints moving. It's not high impact and it's just a really gentle exercise. And here in Florida, we're very fortunate that pool season is all year round. And quite a few people, I would say like 80% of people have a pool in their backyards. So if one of my patients has a pool, usually I tell them, okay, after you've had a tough treatment with yours truly, go to your pool, do some walking around in the pool, just do some movement in that weight-free environment, right? To keep things moving, keep the juices flowing. Thank you, Brian. I appreciate you guys sharing those videos. Really do, really do. All right, guys, so we're going to go ahead and officially get started. For those of you joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in hot, sticky, sunny Tampa, Florida. Yes, it's still hot, sticky, sunny. I see people posting about all the fall leaves changing colors, and I'm like, not happening here. Guys, a couple of good questions for tonight. All right, first one. Popping, knee popping. So Shirley asks me, why do I have a lot of popping on the inside of my knee? The other night I stopped and started walking and I had tons of pain, right? That put tears down. Okay, so she's going to go, this particular individual is going to go and see the surgeon. All right. So here's the thing with knee popping. The official name for knee popping is crepitus, right? And that's really just a fancy way of saying knee popping, the Rice Krispies, right? That's usually what it sounds like, is like a little crackling going on in the knee. Okay. And for the most part, it's kind of part of the normal aging process, right? At some point or another, people usually develop a little snap, crackle, pop in their joints and in their knees. Okay. That can actually be due to buildup of little gas bubbles inside of your knee. And then as you move your knee, you'll hear little pops, the same way as when you crack your knuckles. It's actually the release of a little bit of gas bubble within the joint itself, right? It can also be due to something like arthritis, right? So when I hear about people who say, yeah, my knee makes a lot of noise, usually it's just pretty benign. Now, when someone tells me they have a lot of snap, crackle, popping in their knee and they're in a lot of pain, that's something different. That's something that needs to get checked out, okay? Whether it's because the arthritis is having a flare-up, whether there might be a little bit of a tear somewhere in there, a little tear in the ACL in one of the ligaments, or maybe in the cartilage in one of the meniscus that's in there, that's something that warrants getting checked out, right? There's an inflammatory process in there that's causing pain, right? So get it checked out. Another thing in terms of popping, right? So when you hear a true pop, that's usually when you have an ACL tear. So that's one of the big ligaments in your knee. And usually you see that a lot in sports like basketball, right? That the person will hear, and you can hear it. It's like a loud pop, right? And they know that their ACL is torn. But for the everyday, snap, crackle, pop type thing, again, for the most part, if there is no pain, knee popping is actually a pretty benign process. All right. Hey, Linda from Hurley. How you doing? Glad you could join us. Marianne says, I blame my shoulders, early morning pain on old age. And guys, we get creaky. Honestly, I've had crepitus in both of my knees since I was in my late teens, early 20s. Thankfully, no pain associated with it. That's just how my physiology works, right? All right, we've got Keith Oakley from Myrtle Beach, South Carolina. Hey, Cindy, glad you could join us. All right. Guys, feel free. Yes. So Debbie says she's tore her meniscus. So painful. Yeah. No, usually, again, when something is wrong in our body lets us know about it with pain. Pain is actually a good thing because it does let us know that something is wrong that needs to be looked at. Right? Okay. So, hey, Doug, so glad you're here this evening. Yay. All right, guys, if you got any questions, go ahead and feel free to throw it into the comments section right now. All right, this next one. Excuse me while I take a sip of my really yummy decaf by my daughter. All right. This next question comes from Marianne, right? So Marianne's in the process of trying to get some approval for her C legs, literally her C legs, from Ottobock, right? And through her insurance company. So it's one of their higher end microprocessor knees. And in order to do that, she has to be classified at least as a K3, right? So just a quick tutorial, right? Medicare created the K-level system years back, right? And it's basically a way to classify an amputee according to their mobility level, right? And it's kind of a crude system. A lot of people think it's outdated. I think it's a little outdated and needs updating. But it's basically to say, okay, if you fall into a certain level, these are the kind of prosthetic devices that would best suit your mobility level. So a really coveted level among above the knee amputees is the K3 level, because at the K3 level, you then become eligible for some of the microprocessor needs, some of the higher end, higher technology needs, right? So how do you go about getting classified in a K level? How do you go about demonstrating to insurance, right? So the K level is classified by the doctor. They are the ones who have to officially put the K level on paper. But God bless our doctors, many of them don't understand how the K-level systems work and how to test accurately. So they'll usually send the patient off to the prosthetist or the physical therapist to do the official testing for the K-levels. And oftentimes you'll see sometimes in certain prosthetists, they'll just send in their notes and off they go. But oftentimes the insurance company might deny that, right? They might need more evidence that this person or this individual is in fact a K3 level, not just based on the word of the prosthetist, right? So enter functional testing, right? And you guys have heard me, I've talked a little bit about functional testing on the show. So as a physical therapist, we have a lot of tools called functional tests. And it's exactly that. It is testing your functional mobility. And oh my gosh, we have a lot of tests. I mean, we have well over 100 functional tests available to us as physical therapists. So the ones that I like to use, right? I have a couple that I like to use. I like to use one called the Amp Pro, also the Amp No Pro. It was created by Bob Gailey. I like to use the 10-meter walk test. I like to use the 2-minute walk test. I like to use the 4-square step test, okay? And I also like to use the Houghton scale, okay? Now, each of these functional tests, the Amp Pro is probably the most comprehensive. It's the one that tests a whole bunch of different things. And these other tests that I named are a little bit more specific. So let's just pick for example, the 10-meter walk test, okay? With the 10-meter walk test, we're measuring to see if the person can speed up and slow down. And they can do this with a walker. They can do this with the prosthesis on, with the prosthesis off. So it's measuring to see, can they change their cadence? Can they speed up and slow down, which is a hallmark sign for a K3 level. Okay. In other tests, for example, the 4-square step test, I really like that one because it really challenges and it measures the person's balance, right? Their ability to move across different planes. Each of these functional tests has like a standardized set of scores for amputees. All right. So put this in the back of your head, guys. There's a lot of functional tests out there that PTs can use, but not many of them have scores that are specific to amputees. All right. And that's really important because if you're doing one of these functional tests and you're looking at your scores and they're low compared to the norm, it's because the norm was being measured with people with 2 anatomical legs. So these specific 5 tests, and what I also like about these 5 tests that I personally use in my practice is that, again, it's measuring a little bit of everything, right? So if a person perhaps doesn't perform as well on one test, but they perform really well on the other 4 tests, and overall they present as a really strong K3, that's what I try to submit to the insurance company, right? So what's really nice is a couple of the prosthetists in my area are starting to kind of, get with this, and they're starting to call me to do some of these functional tests. When it comes to functional testing, guys, it's really the physical therapist that needs to be doing this. Now, can a prosthetist, a well-trained prosthetist, learn how to do some of these functional tests? Yes, and I do know of a couple that have been very well trained and they know how to do the test properly and accurately, and they know how to document it accurately. But it is mainly the PT territory. So if this is something that you're working on, if you're somebody who's trying to get approval for a higher level device by improving your K level, okay, asking a physical therapist to do these functional tests so that it can be submitted with the insurance paperwork can really help, okay? So let's see, a lot of comments that came in. I want to read some of these. Hey, Daryl, glad you made it. Here we go. Denise says, I use a pin lock liner. So Denise says, I use a pin lock liner. I get 2 roughly every 6 months. What insurance will pay for? What do you think of buying an additional liner out of pocket? My tibia actually starts wearing a hole in the liners around the 3.5 month mark. Having an extra one in the rotation would help a lot, or should I try to pursue insurance replacing my 2 liners every 4 months instead? That's a good one, Denise. So yeah, the majority, basically everybody I know of, they get 2 liners every 6 months. And I do have some patients who are much more active and they wear through their liners. I would say yes, absolutely. Try to petition your insurance company to cover it for you every 4 months if that's what you're wearing through. Okay. There are a couple of I call them fix-a-flats, but that's not what it's called. There are a couple of devices out there that help with like patching up the liner, especially in the BK liners around the rims, the trim lines where that, you know, it kind of eats away at the liner a little bit more. So there are a couple of devices out there to help extend the life of the liner a little bit, Denise. But I would say, yes, petition your insurance company to try to cover it. You know, the worst they'll say is no, right? And if you're willing to pay out of pocket, I say it's worth the effort. If it's going to allow you to continue to, you know, do everything in your life, you don't want to be walking around with a liner that's completely worn out. That's going to lead to problems with your skin, blistering, you know, not being, you know, completely efficient with your walking. So yes, try to push that through the insurance company. And again, your prosthetist will know how to use the right jargon and saying things like this is medically necessary for the patient's quality of life and safety and for skin integrity, you know, using sometimes those really key phrases to show this is why the patient needs it every 4 months versus every 6 months. So those kind of key phrases, Denise: skin integrity, quality of life, safety with balance, right? All right, here we go. Debbie says they casted my new leg and they are going to make the one I have now into a water leg. Oh, that's so awesome. I kind of like that about living in Florida is the prosthetists here. They make beach legs and pool legs all the time because that's what we do here in Florida. So that's a really great hack. One of my favorite hacks is when you get the old socket, and as long as it's not causing pain or in any, you know, major issues with the old socket, they just remake it, put a nice little, you know, not terribly expensive foot on the end of it. And that's the beach and pool foot, which is kind of cool. Daryl, glad you made it again. So Cindy asks, if you already have an older C leg, do you have to go through all of that again to get a newer C leg? Okay, Cindy, I'm going to be very honest with you. When it comes to insurance approvals, I have a very umbrella knowledge of it. The specifics and getting into the weeds part, that is not my forte, mainly because of the fact that as a physical therapist, I'm not the one ordering the prosthesis. So this is just kind of what I pick up in working with my local prosthetist. So my impression would be, Cindy, is if you were already approved for a C leg, meaning that's the current knee that you're using, that means you were qualified as a K3 level. So when it comes time to bring a new knee, to reissue a new knee, you know, if the timing's up, right, insurance is going to pay for a new knee, my guess would be is that the prosthetist is going to submit the paperwork to show that you have continued to demonstrate competency at a K3 level. Okay, so I've never really heard of somebody who used to have a K3 knee and then were denied later on if they were continuing to function at a K3 level. Now, if the person was a K3 and life happened, something happened, and they're no longer functioning at a K3 level, then the insurance company may not want to cover it. You know, but for the most part, if that's what you were, that's typically what you get for your next knee when you're up for a new knee. Bonnie asked, do the functional tests work on Stubbies and Sidekicks? So Bonnie, do you mean, can I do the functional test when a person has Stubbies or Sidekicks on? And the answer to that would be yes. Now, I will say this, Bonnie, when it comes to these functional tests, they do have amputee scores, but unfortunately, they don't specify between below the knee, above the knee, and bilateral. That still needs to happen, okay? So when you are a bilateral, right, the way I would approach, and actually I had a bilateral above the knee about 5 months ago come into my clinic. I can't remember. 5 months ago, this gentleman with a bilateral above the knee, and I had to kind of rearrange things on the functional test. Now the AMP Pro, that's probably the gold standard right now for functional testing for amputees. That one, you do have a place to indicate that the person, what level of amputation that they have and whether or not they're bilateral. Okay. For the other functional tests, I document. Okay. I'll say, yes, the person scored lower, because typically as a bilateral amputee, you will score lower because they are a bilateral above the knee amputee using Stubbies, using Sidekicks. Like I document the heck out of everything there so that the insurance companies can get a very clear picture. And then as just an added lump into it, I also submit the literature. That's another thing I like to submit, because a lot of times, sometimes the person reading the insurance, claim is going to say, I don't really know too much about this functional test. So I submit, this is why as a physical therapist, I use this particular functional test. It measures for this, and this, and here's the literature behind it. So basically it's silver platter, here you go, okay? And this is something, guys, that all physical therapists are trained to do. Hey, Tom, glad you could join us. So Susan says, I get new liners every 3 months and sleeves every 3 to 4 months. Susan, do you mind telling us if your insurance covers that, or do you have to pay out of pocket? Cliff, dude, haven't seen you in a long time, man. Welcome back. Debbie says, my boyfriend would yell at me to slow down, so I'm used to speeding up and then slowing down. So you demonstrate varied cadence, Debbie. Cindy says it's 6 years old. Cindy, honestly, I don't know. And if anybody has an answer here, if I have any of my prosthetists on board listening tonight, I'd love for you to chime in on this one. How long it is in between microprocessor knees. Okay. Van Gregory asks, should a physical therapist or a prosthetist do the functional testing for disability determination? Okay. So actually, I haven't had to do that in a long time, Van Gregory, I'll be honest. It should be the physical therapist. The prosthetist certainly needs to submit supporting documentation, obviously documenting the equipment, the prosthetic equipment that will be needed by the amputee, right, in their life. The physical therapist is the one who talks about the functional mobility of a person, right? We're the ones who talk about the movement in their life, everything from walking to transferring, right? So, and the occupational therapist as well also plays a very, very, very strong role, because they're talking about all the ADLs, the activities of daily living, right? Gotta show my OT some love, man. So when it comes to determining disability, right? And disability is determined by function. How much can the person function in their job? That is the physical therapist, okay? And oftentimes back in the day when I worked in insurance-based clinics, right? That's how we would also support our request for continued physical therapy, right? We would talk about not just the fact that the person had muscle weakness and missing range of motion and decreased balance. No, we would phrase it, we still do, phrase it in terms of functional mobility. And here's what I mean by that, Van Gregory. We would say the person is demonstrating decreased muscle strength in this group, which is decreasing their overall balance, which means they are unable to perform such and such duty while at work. Okay, you got to provide the whole chain. So when it comes time for documenting for disability purposes, it's a very similar approach. You have to document how is it that the impairment, right? How the impairment of the muscle weakness, of the amputation, of decreased range of motion, decreased gross motor strength, whatever, vocabulary you want to use there, and how the impairment contributes to the disability. Yeah? Thumbs up, makes sense? Good question, Van Gregory. What's a sidekick? It's one of my favorite feet. I really need to hit College Park up and have them send me one, because I talk about it a lot on the show. I wish I could model it here for you guys. So the sidekick, Marianne, is a type of stubby foot. Okay, so basically a stubby foot, some people also call it like a goat foot. It's like a little rectangular shaped, just a little piece of rectangular shape. And it's usually put onto the bottom of a socket for above the knee amputee, for bilateral above the knee amputee. So when folks who are bilateral above the knee amputees, meaning they're missing both of their legs above the knees, they usually start off with these stubbies, right? So it's the socket and then a little foot at the bottom of the socket. And this allows the bilateral amputee to learn to kind of start walking without being on full length legs, right? Because that can be pretty daunting task. It allows the person to start develop strength and a lot of endurance, right? So one of my personal favorite stubby feet is the Sidekicks by College Park. It's a little bit of a wider one that I'm used to seeing than most of the ones that you see out there. And it's got a nice tread on the bottom, but more importantly, it's got movement. It's a multi-axial. So with a lot of these other stubby feet, it just sticks to the socket and that's it. You're just kind of walking like this, right? So with the Sidekicks foot, you do have some movement in there. So yeah, big fan. And also, as a side note, the Sidekicks can be used as a beach foot and as a pool foot. All right, so Susan says her insurance does cover the liners every 3 to 4 months. Or your insurance pays for 80% and you have a copay. Okay. Oh, Brian, thank you so much. I appreciate that. Hey, compadre, man. Glad you could join in. All right, Chuck. Oh, listening in from the YouTube channel. And guys, just as a reminder, I always keep forgetting to say this. I am streaming to my YouTube channel. So for those of you, I know some of you have been trying to get some of your friends to kind of join in on the show, but they may not necessarily like being on Facebook. So my YouTube channel under Cosi Talks, really easy to find. And here's my shameless plug. I've got a lot of great videos on that YouTube channel, guys. Check it out, subscribe, try to get those numbers up so I can get the word out more. So if you have a chance tonight, please go to my YouTube channel, hit subscribe. Barbara, where you been? You haven't been here for a couple weeks. Missed you. All right, here's a good one. So this is the part where I'm going to ask you guys for some help. If there's anybody here tonight who has experience with this particular issue, I would love if you could chime in. All right, so this particular individual reached out to me. She had a knee replacement in March and got a really bad infection, and she lost a lot of the skin over the knee as a result. She had to have skin grafts put in on May, and she had to have the knee immobilized for 4 months, right? So as a result, she had to go back to surgery to get a manipulation on the knee because after being immobilized for 4 months, that knee was not going to move. So she had to go under anesthesia to break up all that scar tissue in the knee. So long and short of it, apparently the knee is not doing terribly wonderful, right? So she has a lot of limitations in the range of motion. And one of the possible options down the line for her might be amputation, right? So this particular individual heard about me and about what I do, and she reached out to me and asked for my advice in terms of what were my thoughts, okay? So here are my thoughts on her particular case. And again, I know that there are several of you who have been on the show that you ended up with an amputation because of a knee replacement that went bad, that had an infection on it. So if you have any advice for this individual, I'm sure she would love to read about it or hear about it if she's listening right now. I know, Susan, it's a little heartbreaking. This is a very active individual. This particular individual is quite active in her lifestyle. So here's my advice. Apparently she's got 6 months, okay, before she goes back to the surgeon and before she's eligible to do any other kind of surgery, right? So, and she's doing aggressive physical therapy, which is wonderful, right? So my advice to her is stay the course, right? Do the physical therapy, do everything that you can in these next 6 months to try to gain back function in your knee. The other thing I suggested to her is talk to your physical therapist and ask them to see if they can teach you how to do hiking. That's her particular favorite activity. How to do hiking in a way that is adaptive to what your knee looks like right now. And again, I haven't seen this person. I haven't seen her in person, so I can't, evaluate what's going on. But if she has the balance and the strength and the safety to be able to do some easy hiking, for example, with 2 hiking poles, okay, to try to find ways to adapt between now and the 6-month mark when she goes back to see the surgeon, okay? For me, guys, it's a way of leaving no stone unturned, right? It could be that there's a way for her to adaptively do some of these activities again. And she might decide, you know what, she'd rather live with these adaptations, right, versus going in for an amputation. Or it could be that none of the adaptations are working, right? So in my mind, it kind of helps her. It might help this individual have a clear head and a little bit more discernment when making this really difficult decision, okay? And I know many of you had to make decisions similar, where you had to go through multiple surgeries, whether it was because of a knee replacement or something else going on, before finally making that decision to have an elective amputation done, okay? And then the next thing is ask questions. Lots and lots and lots of questions. The first question being is, how can she, if it comes to having an amputation done, how can she preserve the maximum amount of length in that bone, right? And this is something that many surgeons, this is the primary goal of surgeons, but certainly as a patient to advocate for that, to say, you know, is it possible for her to stay as a knee disarticulation patient, right? And get all of this information done, all right? Let's see. Let's see what you guys have to say here. Hey, Kevin, glad you could make it. All right, Kim, I'm glad you're here listening. So Susan says, exactly, exhaust every option before amputation, in my opinion. So Kim has posted her number there. So if anybody has any advice that they would like to share with her, any other options, hey, Patrick, glad you could join us this evening. Brian says, researching ahead is a great thing. Keep up until moving ahead, until this decision feels okay in your world. Yeah. Brett says, start strengthening your core now. And it sounds like she's having some really great physical therapy. So that part makes me go, okay, she's in good hands. She's getting good physical therapy done to do everything that's possible there. So guys, thank you guys for putting some advice out there. Keep it coming, right? This is one of the big reasons I do this show. So here's another part of it, right? So I've done a lot of talks lately on TMR, targeted muscle reinnervation. And Kim, this is something else you might want to listen to as well. Sandra says, not just gain function with knee, but upper body as well to prepare for amputation. Something similar happened to me and started physical therapy. And as though the amputation has occurred. And that is one way to look at it as well, Sandra. Back in the day, way back in the day, people actually received physical therapy prior to surgery to get strong for surgery. And insurance covered it. And they stopped covering it, which to me, it's just like, So back in the day, and we're talking like early, mid-90s, late 90s, insurance companies would cover a 6-week treatment of physical therapy prior to a person going in for a knee replacement or a hip replacement to get them strong. And then they'd pay for physical therapy after the hip and knee replacement, right? I remember when I was in high school volunteering at one of the local Health South clinics, you know, we had a young girl in there who had completely ruptured her ACL tendon, right? And she was in there for quite some time getting physical therapy done to get her nice and strong prior to her surgery, right? So yeah, I wish that's something that would come back a little bit more, but yes, you know, prepping for surgery, the stronger you are going into surgery, the stronger you'll be coming out of surgery, the faster you'll bounce back from that, okay? Our pleasure, Kim. So guys, here, I know, right, Kevin? So guys, here's something that happened this week regarding targeted muscle reinnervation and RPNI, regenerative peripheral nerve interface. Mouthful, right? So I've done a couple of shows on those two particular surgical procedures. And these two surgical procedures, long and short of it, I won't go into the whole show again because, like I said, it's a whole show. But they're meant to deal with neuromas, right? So quick and dirty, when you're having the amputation, surgeon takes the nerve, cuts it, nerve goes back into the soft tissue and it burrows itself in there, right? It starts forming scar tissue and it starts causing pain, right? Nerve pain, which is really not pleasant, right? And it can either be localized nerve pain, meaning the pain is all in the limb itself, or it can start causing some really bad phantom limb pain, right? So surgeons over the years have started doing what's called targeted muscle reinnervation, where they take that nerve ending, right, and they plug it back into the muscle, right? This allows the nerve to start spreading little rootlets, right? And it makes it happy. Why? Because nerves belong inside of muscle tissue. That's what they're meant to do. That is their whole reason for existence, right? To innervate a muscle, right? So with the RPNI procedure, it's a similar procedure in the sense of its purpose, right? Its purpose is to give that nerve something to do. So instead of plugging the nerve into the big muscle with RPNI, they take a little piece of muscle graft and they wrap it around the end of that nerve, right? With the same purpose, to give that nerve something to grow into, right? So we've talked to this a lot on the show. I've had a wonderful surgeon, Dr. Leonard Dedesi. He's an orthopedic surgeon out of Pennsylvania. He's been on the show to talk about it a couple of times. And this is something that people are starting to finally become aware of. Okay. And I advocate a lot for those of you who know that you're going to have an amputation, like either it's because your second amputation or like in Kim's case, you might, be facing a first amputation. I highly encourage people to find a surgeon that is well-versed in TMR and RPNI surgery. Okay. Because this is something that if it's done right at the time of the first amputation, your outcomes are going to be better with regards to pain, because if the nerve is in that muscle, it won't form a neuroma, right? Now, for those of you who have had your amputation already and you're possibly facing a revision, will this work for you? The answer is yes. The efficacy may not be as strong as when you have it right at the first amputation, but the literature is saying that yes, it will work, okay? And those of you who have been dealing with an active neuroma, right, and it's been causing problems with your daily function, right? This is something to consider. This is something to have a conversation about with your surgeon, with your doctor, with your prosthetist and PT, if the conservative methods of relieving that pain aren't working, okay? Cindy asks, so Susan asks, I wonder why the surgeons always didn't have the nerve reintegration. This procedure's actually been around for the past 20 years, but it started off as a procedure for the arm amputees. And we talked about this on my show that I did. It was basically meant, the targeted muscle reinnervation was a way to prepare the nerves that were left, right, to be able to use a myoelectric upper extremity prosthesis. And myoelectric, some people call them the mind power prosthetic devices. So the higher technology, okay? So when it trickled down to the lower extremity amputees, right, they started realizing, wait a second, this is a really great way to treat neuromas and also help with phantom limb pain, okay? So Cindy asks, if you have that pain like that, should I go find an orthopedic surgeon? Yes and no, Cindy. And this is where I had, this is the reason why I'm bringing all of this up is because I had a really lovely conversation with another viewer this week. We were emailing each other back and forth because this particular viewer has had a lot of residual limb pain. And this viewer has had revision surgery. This viewer has had back surgery. So it's been through a lot of different things with this particular viewer. And in asking her several questions, I realized, you know what? She might have a neuroma, okay? The point I want to drive home with this, and I mentioned this to the person as well, you need to know what you're looking at, okay? If you start throwing narcotics at it, if you start just saying, okay, let's go do a revision, or let's go do injections, or let's go do this, it's like throwing spaghetti to the wall and seeing what sticks. You need to accurately diagnose what is going on. Okay, there's a lot of things that can contribute to pain in the residual limb, right? We've talked about some of those things on the show. Let's see if you guys remember. Let me see what kind of students I have here today. How many of you, what can you name for reasons for pain in the residual limb? Let me see you put it in the comment section. Susan asked, can they do it years later? Yes, Susan, they can. Keith says he had the TMR done on April 14th of this year at Duke, and the pain is completely gone. Susan asked, can a neuroma be detected by x-ray? You know what, Susan? That is a great question. I'm going to go with I don't know, because I don't like, if I don't know something 100%, I'm not going to try to baloney the answer. My guess, Susan, and I'm going to actually follow this up. I have a dear friend who's a radiologist, so I'm going to go pick his brain about this one after the show is over. But I would imagine if it's a really big neuroma, and there was a picture I found the other day, and it was a big old honker of a neuroma, that will show up as some sort of maybe opacity on the x-ray, maybe. But from what I understand, ultrasound or MRI is another one. Oh, Volker, thank you so much for those kind words. I appreciate it. We got a lot of questions coming in. Let's see if you guys remember. Pain in the residual limb. Patty says from infection. Brian says from bottoming out. Very good. Ben Gregory says from falls and bumps. Yes, absolutely. Debbie says from nerve pain. Bone spurs. That's another one. Bursitis, right? Cysts, right? So there's a lot of things, guys, that can cause pain in the residual limb. Okay, so you got to know what it is to know what you're treating. And I know that sounds like obvious, but I can't tell you how many times people come to me and they say, well, the doctor just gave me pain meds. Did they diagnose you with anything in particular? No. They just said it was part of being an amputee. Okay. So for this individual, guys, if you suspect that you have a neuroma, right, you want to go see a surgeon who knows what a neuroma looks like and knows how to look for one, right? Because they're going to be able to tell you if there is one or not, right? So my really long-winded story, sorry, and I know I'm taking a long time to get to the point, is this particular viewer was saying how she wanted to find a surgeon who did TMR. So I said, okay. So I did a quick Google search, and I'm like, targeted muscle reinnervation in this state. Nothing, right? I'm getting nothing. And I'm like, okay, I know that there are surgeons out there in this particular state that do TMR. Why can't I find it? And I guess my guess is that the SEO, on the Google search engine was not picking up on these particular surgeons' websites. So did a little digging, and I found a company called Checkpoint Surgical. Okay. Checkpoint Surgical is a company that manufactures medical devices. And one of the things that they manufacture is a tool that surgeons use during TMR surgery. It's like nerve finder tool, for lack of a better word, right? So I sent an email to this particular company, and they answered me right away. And they gave me a link to a physician directory. I know. Crowd goes wild. Y'all, I was jumping up and down in my seat when I read that email and I saw that link. And I'm putting that link up right now. Bam. Okay. Guys, show that link some love, okay? Because I've been looking for this link for a long time. It's a really lovely website with a lot of information about TMR and RPNI. In there is a physician directory, and you might recognize one of the names of the physicians because the surgeon that was on my show is on that directory. And that directory is a nationwide directory of physicians who have chosen to be placed on there, and that they are trained and experienced in TMR surgeries. And you're going to see, guys, orthopedic surgeons, neurosurgeons, you're going to see plastic surgeons, right? And you're going to see general surgeons. You're going to see several different types of surgeons that have had specialized training for this procedure. Okay. So guys, should everybody go run out and go get revisions done in TMR? No. But if you're somebody who's having residual limb pain, okay, it might warrant making an appointment with a surgeon who's done TMR, because they are going to be the ones who can diagnose you to see if you have a neuroma or not, right? And then go from there, right? All right, guys, let me go ahead, and I'm missing some comments, and I don't like to miss comments. Hang on, folks. So yes, Cindy, to answer your question, it could be an orthopedic surgeon, it could be a plastic surgeon, it could be a neurosurgeon, it could be a general surgeon who does this. Excuse me. Susan asked, can they do it years later? Yes. Now, excuse me, guys. When Dr. Dedesi was on the show, he mentioned that the sweet spot, right, is to have the procedure done within the first 18 months after the initial amputation. Meaning if it wasn't done during the initial amputation, that ideally you want to have it done in those first 18 months. Now, is it to say that you can't have it done later on, especially if you're having big problems with neuroma pain? Absolutely not. You can have it done, okay? Brian says, went through neuroma in my second year, took some time healing for sure. Keith asks, how can I find a physical therapist in my area that's well-versed with amputees? Keith, Dr. Google. This is the only time I tell you go looking on Dr. Google for information. That's how I do it, Keith. I do have a couple of contacts here on Facebook, and we have one private group on Facebook for physical therapists who are practicing amputee specialists. So sometimes when I have somebody in a particular area ask me, I'll go and say, hey, is there a physical therapist in Baton Rouge to see if we can, get them some help. So it's hit or miss. I will say this, Keith, search Google, a lot of physical therapists out there who work with amputees. We are highly, advertising our skills out there because we know that there's not many of us out there who practice this particular specialty. Also, talk to your prosthetists, right? I've had more than one case where the patient connected her physical therapist who didn't have any amputee training and connected them with the prosthetist. And the prosthetist was able to kind of fill in gaps of whatever information the physical therapist needed to do the prosthetic training. So there's a lot of ways to kind of think outside the box with that, Keith. Susan says her prosthetist thinks that she has a neuroma. Okay. Brad, I just saw your comment. You're hysterical. So Bonnie says 2 months ago, I had the bilateral and above the knee amputation, and they did the RPNI, which is the sister surgery. I call it the sister surgery, the TMR. It's where they take the muscle graft and they wrap it around the nerve ending. The difference between the first amputation was where it was just a standard amputation below the knee, and the difference between the two procedures was unbelievable. So Bonnie, thank you so much for sharing that with us. Marianne says, my vascular surgeon took my legs to save my life, but would not recommend a prosthetist guy because he said I would never walk again. There's good and bad ones in every bunch, Marianne, whether it's surgeons, PTs, prosthetists, nurses, OTs. There's always going to be a couple of bad apples. Don't listen to them. I'm so glad you didn't, Marianne. So I'm glad you're moving forward regardless. Let's see. Scar tissue. Yes, Paul. Scar tissue is another big one that can cause pain in the residual limb. And that's exactly what the neuroma is. It's the scar tissue that's formed around that nerve ending. Poor prosthetic fit. Thank you, Patrick. There's my physical therapist right there. Poor prosthetic fit can cause the residual limb pain. And here's another one. Actually, last night I did a really lovely webinar with Vital Fit. And guys, I'm going to throw in some love here for my Vital Fit sponsor. Go to their website. They're doing webinars twice a month, right? Educational webinars. And last night's webinar was all on TMR, RPNI. Maybe that's why I'm on that kick right now. But Greg Menino, one of my co-hosts, amazing prosthetist. He's an above the knee amputee himself, amazing athlete. And he was just saying, one of the things that will fire off a neuroma in his patients that he sees is when they come in and their socket has been fit too tight for them, whether because they put too many socks or the previous prosthetist made it a little too tight. All right. Tom says, overdoing it like running a marathon. Well, that's kind of a good kind of pain, though. I'm kidding. I'm kidding. Tom and I are both running heads. All right. Susan says, I've been taking narcotics for almost 9 years now. I don't even know why, except my residual limb always hurts. And again, this is something I hear a lot from my patients. And I have a lot of patients who say that they want to come off the narcotics. And this is something that I support, but that it needs to be done very carefully. If you are on narcotics, especially those of you who have been on it long term, coming off narcotics is something that has to be done under the supervision of a doctor, specifically a pain management doctor, to help prevent withdrawals, right? They can be pretty nasty and can even lead to death sometimes, okay? So that's my public service announcement there for coming off narcotics. And the other side of it is, trying to find out what is the reason behind it. What's the reason behind it? And sometimes you got to knock on a few doors to find the person who can accurately diagnose it, Susan. Patty asks, do neuromas come back? If they are left flip-flopping around in the soft tissue, yes, because what happens, and this has been the traditional way of treatment, is that they would go in there and they would carve out the neuroma, right? Take out all the scar tissue, clean it up, make it nice and pretty. But then they leave that nerve ending in the soft tissue, right? idle hands make devil's work. So if that nerve ending is still floating around in the soft tissue, chances are high, right, that it's going to start to form scar tissue once again and cause a problem again. Now, I have had some people that said that they had the neuroma just resected without TMR and they did fine. But my opinion is, if you're going to go under the knife to have a revision done, to have a neuroma resected, why not just plug it back into the muscle? Yes? Okay. Crickets chirping? Oh. Patrick with the fancy stuff. He's saying contralateral weakness causing compensatory strategies on the residual side. So what he's fancy, Mr. Fancy Pants there, is saying is when a person has weakness on their sound limb, right, it's going to start making the residual limb take up more of the slack, which can cause pain, which can cause overuse injury. Wow, smarty pants here tonight. I love it. Jim, I am so glad you made it tonight. Jim, did you get my email? Did you get my email? Let's see. Sorry, guys, scrolling through these comments, trying to get the questions out of here. Susan says, I guess I'll have to ask my AMP specialist if I even had the nerve integrated surgery at the time of amputation. And that's a very good point, Susan. A lot of people, they don't know. They didn't know about, about TMR going into their surgery. So they're not going to know if they had it done or not. But that's something that's easily, you can look that up on the op report. That'll be on the op report. Oh, Leanne, thank you so much. Yeah, and then honestly, that's what it is to be. It is part as a physical therapist is detective work, and that's part of one of the many reasons I love what I do. When people come in and they have these issues with the pain, it's really like a puzzle trying to figure out, okay, what is causing it? What's not causing it? What can we test? What can we rule out? What do we need to send them back to the doctor for to see if they can maybe run some tests for us? So from the nerd side, it's part of why I like being a therapist. All right. Let's see. Whoops. Ben Gregory, love you, man. Thank you. Thank you so much. Thank you. And do you know that individual ended up buying a coffee mug? I know. So it's kind of awesome. Kevin, my pleasure. Absolutely my pleasure. Let's see. Jean says that she read an article on above the knee amputees, and it said many develop osteoarthritis of the good knee caused by the way they walk and too much weight on the good limb. Be careful with our good knee. Yes, and that's something I definitely hit the nail on the head a lot in this show. When you're using a prosthesis, it's natural, right, to favor the sound leg. Even some of the best walkers out there I've seen, and I'm thinking of one prosthetist in town. She's a beautiful walker. She's an above the knee herself, extremely active, but even she'll tell me, she's like, yeah, when I'm in the grocery store, I'll hang on my sound leg just because it's easier, right? But that is going to cause a lot more stress on that sound leg. And very rarely will you get an equal 50% walk, a gait pattern with a prosthesis. It's very rare. It does happen, but we can get as close to that 50-50 as possible and keeping everything nice and strong. And the way I see it, guys, as our bodies age, whether you have one leg, two legs, or no legs, right, you got to use it or lose it. You got to keep strengthening. You got to keep everything going and keep everything nice and strong. Otherwise, you're going to develop some of these nagging injuries. Yeah, it's no big surprise that the majority of the physical therapy population in outpatient centers are going to be the population over 50, right? Harsh, there you are. Hadn't seen you all night. Yeah. And Susan, again, that's something that you need to, and depending on how it is that you are, if that's something that you want to change, then you need to, talk to a pain management specialist. Yeah, Cindy. And sadly enough, I had, Cindy says, I can't even imagine having a revision. Sadly enough, I had an individual come into my clinic this week, young man, very young man. And he walks amazingly. Very rarely, I can count the number of times on one hand, will a person come into my clinic and there's nothing I can do for them in the sense that they are walking that well, right? So this is one of those individuals, but he's in a lot of pain, a lot of pain. And it's pain to the point that his surgeon has recommended a revision because there are problems in his leg. And guys, I want to hear from you on this one. I'm very curious to hear what you all have to say. And I'm sitting there looking at this young man who is very depressed. And he has the potential to do running. He has the potential to do sports again, right? And I'm telling him this. I'm telling him, walking, you're doing great. You're despite the fact that you're in this much pain, you're walking beautifully. But you're not going to be able to do the sports and all those things with the pain. You're going to have to, get that taken care of. And he just said, I refuse to get a revision. And he goes, I cannot imagine going through that pain again of surgery. And as a physical therapist, you're sitting there going, okay, what do you do with that, right? And those of you who may or may not know, I have a personal history with breast cancer, and I had to undergo 4 or 5 surgeries myself, in rounds of chemo. And, with every surgery that I had to be faced with, it was just do I really need to go through this again? The prep for surgery, the recovery from surgery, and all that comes with it. And yeah, nobody wants to go through surgery. So for this particular young man, I kind of took my physical therapist hat off and I put my former cancer patient hat on. And I just basically said to him, I go, it's your body to make a decision. Nobody can force you to have surgery. It's not a life-threatening issue that you have going on right now. But you need to ask yourself, do you want to live with this kind of pain every day for the rest of your life? Or do you want to go through the pain of revision again? And with a high chance of probability, you're going to get relief from that pain. And I told him, I was like, it's your decision, obviously, So I'm curious to hear from you guys. How many of you have been faced with that decision where you were recommended to have a revision, right? And you decided not to have it done because you didn't want to go through it again. And to me, there's no, guys, let me just put it out there. There's no right or wrong answer here. It's a very difficult decision to make. And again, my heart just broke for this young man sitting in front of me. And, along with, even though I don't need to treat him as a physical therapist, I am trying to find him resources for the Amputee Coalition, and resources for emotional support, because that's honestly what he needs right now. But I'm curious. Talk to me about this one, guys. Bonnie says, does the phantom sensation go away when you start using prosthetics? Yes, it does get better. That's the kind of the general trend that I've seen in practicing for the past 18 plus years, Bonnie, is that the sensation decreases with time. With some people, it goes away completely, but for most people, there is some sort of sensation that's there. And sometimes it stays constant, but usually over the course of time, it just kind of becomes intermittent. So it only occurs every once in a while. And again, everybody's different across the board with that one, Bonnie. So Debbie says, mine came when I started using mine more with the prosthesis more. Okay, so Denise says, I still have phantom sensations and my amputation was in 2018. They don't hurt, it's just a feeling. Exactly, Denise, and thank you for saying that. Like I feel my foot almost every day at some point, like it's sitting flat on the floor, and I can also feel like I can wiggle my toes. And that's another big thing that I really have brought up on the show, guys, is just knowing the difference between phantom limb sensation and phantom pain and residual pain. So phantom limb sensation is when you can feel your foot, you feel your toes, you feel part of your leg, but there's no pain associated with it. It's just like, it's there, right? Versus the phantom pain where, yeah, that's pain, and it's pain in the place where your foot used to be. Usually it's the foot. Stabbing, aching, burning, crushing, all sorts of kind of pain, right? versus residual limb pain, right? And that's the pain that is in the residual limb itself. And oftentimes the residual limb pain will trigger the phantom limb pain. Good times. Yeah. Susan says she's had 3 revisions. Okay. Brian says, show him Amplitude Magazine, inspirational support and motivation. Brian, I'll tell you what, I was showing him every one of my videos of patients who obviously gave me permission to share those videos, but showing him, and just showing him this is what you can do, so we're gonna keep working on that young man. Susan says, I did all the revisions because I had to. And Brett says, yeah, chronic pain is depressing. It is. Kevin says, I would do it. I'm not going to live with pain every single day. Nope. Yeah. But Kevin says he's never been faced with the issue of having to have a revision. Susan says, I had no choice from my 3 revisions, run one right after the other because of infection. Yeah. Debbie says, I'm terrified of having any surgery. Brian says, as we know, mental health is a huge part. Our well-being doesn't always come first. Yeah. And this is something that, the more I'm in the profession and the more I get to know people out there in the community and trying to make those connections with the emotional support. So my current favorite one is calling on the Amputee Coalition with their certified peer visitor program. And this particular young man, he is Spanish speaking only. One of the reasons why he came to find me. And the Amputee Coalition called me back and they said, yes, they do in fact have a Spanish speaking amputee that fits his demographics here in the Tampa Bay area. So I'm just like, oh, thank goodness he can talk to someone who's literally been there, done that, and can relate to him on a much better level than I can. Keith asked, do I ever discuss osseointegration as an option to revision or unsatisfactory results from their current prosthetic system? So Keith, oh Lord mercy, when was that? At the end of 2019, Keith, and I think it was in September. So if you want to go back to my Cosi Talks Facebook page, right? And in the video archive section, I did a full month on osseointegration, specifically the OPRA system, which is the 2-part screw fixating system that is done by Integrum. So it's a big company that's been doing a lot of these surgeries here in the United States, along with, so there's 2 basic ones. There's the, now I've got to review my literature on this, the press fit and the screw fit. Okay. It's 2 different types of procedures for osseointegrations that are currently available. Okay. So do I ever discuss osseointegration? Yes. I have a lot of folks who come and ask me questions about it. I believe it's a very specific candidate that is a specific person that is a candidate for this particular procedure. So if you want to learn more information on that, Keith, and actually, I think I'm due for an update on that show. What do y'all think? Do I need to do another show on osseointegration? Put it in the comment section. Let's do a quick Cosi poll. Do I need to do an updated show on osseointegration? Is that something y'all would like for me to do? Comments. I want to hear it. Want to hear about it? Yes or no? Like, yay, thumbs up, or mm-mm. Susan says, a good day is when I cannot feel my foot. Not painful, just don't like to feel it. Yeah, I believe you on that one, Susan. Tom says, I had nothing but problems before my revision, and the pain of having my revision was worth it. Best decision I ever made. Jean says, what is the cause of pain in this guy? Bone skin. Poor guy. Can't even imagine having a revision. So Jean, in this particular gentleman, he does not have a lot of soft tissue covering his residual limb bone. So the bone is very close to the surface of the skin. And he might, again, I don't have, other than my 2 thumbs, I don't have official diagnostic tools for neuroma, just my thumbs where I go poking. He might have a neuroma brewing in there. But he has a very good surgeon. So it's up to him. It's up to him to make that decision, take that leap. David says, I've had several revisions to my total knee replacement before my amputation. The pain was excruciating. I hated the thought of revision, but it had to be done so that I could begin to move forward. Ultimately, my amputation came, but now I know I made it right decision throughout the whole process. Life will be better, and it is, and I will pray for him. Thank you, David. Patrick says, can you get phantom limb pain after not having, say, it post-op plus a year or so? Huh. That's a good question, Patrick. All right, guys, more Cosi polls. Put this one in the comment section for me. Have any of you not experienced phantom pain that first year after amputation, and you started developing it after that first year of amputation? I've never heard of somebody with that particular scenario, Patrick. Everyone I know who has phantom limb pain, they felt their first phantom pain weeks, maybe months after surgery, certainly within that first year. And then I have the occasional lucky duck that they never had phantom pain. They had phantom sensation, but not pain. Let's see. Kim wants to know, another question, has anyone had more than one manipulation and got more bend the second time around than the first? And what Kim is referring to is folks who have the total knee replacements that have a lot of scar tissue in there that no amount of beefy physical therapist is going to get more range of motion. The surgeon puts the person under general anesthesia and manipulates that knee and literally just tears through all that scar tissue to get more movement in that knee. So Kim wants to know, has anybody ever had that done more than once? And did they get more bend the second time around? Kim, I have had the occasional patient that they did have to go in for more than one manipulation. And they did get a little bit more range of motion. But again, that's something that everybody is different. Everyone is different. Patty says, I had several revisions, then TMR, which for me did not make pain better. Okay. Faced with RP and I, kind of have mixed feelings about going through another surgery, but I can't live like this for the rest of my life. And I have grandbabies and I want to do things with them. And Patty, I don't blame you there. Patty, I would really appreciate if you could keep me posted on how you're doing with that. I would really love to know. Bonnie says, when I transfer, I feel like I have to lift both my legs, but now I don't have the phantom pain after the RP and I. So isn't that interesting? And guys, when I asked Dr. Tedeschi, he's one of the few surgeons that does both TMR and RP and I. And he kind of chuckled and he said, yeah, when you go to the conferences for the surgical conferences, you're going to have one camp that touts TMR and the other camp that's with the RP and I stats. And in his case, he says that when he looks at the individual patient, he just sees which particular procedure is more specific to that patient, that it's more patient dependent, that he sees the outcomes. In his case, he'll see the outcomes very similar. Keith says that you're also interested in the press fit system. And honestly, Keith, in the past year or so, now that the FDA gave I forget, exemption device, I've forgotten the proper name for the FDA, like the temporary approval, basically, to allow the osseointegration procedures to be done inside of the United States. We're starting to see several clinics pop up everywhere around the nation doing it. Oh, so David says yes on the osseo. Brett says yes. Jim says yes, do the update. Patrick says yes. Megan says yes. William says yes. Tom, oh, you guys are awesome. Ha. Brett says his phantom pain was soon after the amputation. Kevin says it was in the first year and it subsided quite a bit over the past 4 years. Denise says, I don't have phantom pain much, but it did start within the first several months. Debbie says it didn't start until a few months later. David says, here you go, Kim. David says he had 3 manipulations done and mine got worse. I scar as easily and tremendously. Greg! Oh, man, I was just talking about you, Greg. I was singing your praises just a few minutes ago. All right, we're wrapping up talking up on TMR. All right, guys, I'm going to post that link one more time just because I'm just so excited to finally have like something like this resource to show you guys. So guys, this is the link to this lovely company that put together a physician directory of the physicians around the United States who perform TMR and RP&I. Now, granted, this is not a comprehensive list. I'm sure there's quite a few that they left off, but these are the surgeons that they have received the training for it. So if that's something that you're thinking about, if that's something you have questions about, you can look at this directory and think about maybe having a conversation with one of these surgeons. All right, guys, this has been a really, really fun show. I love it when you guys are so interactive and sending me all the feedback. As always, guys, next week it's another general question and answer session. So please send me your questions. That's the whole point for me doing this show. So when I look at my inbox in the morning and there's no messages and no questions, it makes for a very sad PT. I know I'm being a drama queen right now. So guys, send me your questions. And please, if you have time tonight after I shut the show down, please go to my YouTube and hit subscribe. I'm trying to get some of those numbers up so we can help spread the word about this show. So as always, guys, thank you so much for letting me be a part of your lives this evening. I will see you same bat time, same bat channel next week. Bye. God bless.